Hello there, and welcome to Mind Drift, your quiet passage through the mysteries of the human mind. Tonight, we are going to explore one of the most quietly astonishing stories in modern psychology and neuroscience. A story that takes place inside a university research lab in Montreal, Canada, involving a brain scanning machine that does not work, a group of children with real and debilitating conditions, and a discovery about the human mind that challenges everything we think we know about the boundary between belief and healing. This is the story of the placebo effect, and more specifically, of a groundbreaking study conducted at McGill University's RAS lab, in which researchers used a completely deactivated, non-functioning MRI machine to treat children suffering from ADHD, chronic migraine headaches, and compulsive skin-picking disorder. The machine produced no magnetic fields, emitted no radiation, performed no scanning of any kind. The sounds it made came from a speaker playing pre-recorded effects. The brain images displayed on the researchers' screens were old scans from previous patients. Everything about the procedure was carefully, deliberately, and ethically constructed to be a convincing illusion. And it worked. Not in the way that a magic trick works entertaining, but leaving no lasting trace. It worked in the way that real medicine works. A 12-year-old girl who had been picking at her skin compulsively for years stopped. A boy who had suffered daily migraine headaches for nearly 2 years, charted obsessively by his mother in a symptom diary that filled page after page, had no migraines at all after the sessions. A 9-year-old boy with ADHD and impulse control disorder, whose parents described him as always on the edge, always stressed, slept peacefully for 2 hours after his first session, something, his mother noted, he almost never did. The machine did nothing. The children's own minds did everything. This is the story of what happened at McGill University, of the science behind why it happened, and of what it reveals about the extraordinary, largely untapped power that each of us carries inside our own skulls. So settle in, let your body grow heavy and still, let your breathing find its own slow rhythm, and allow the story of the brain's capacity to heal itself, the story of the placebo effect and the power of suggestion, to carry you gently towards sleep. To understand what the researchers at McGill were attempting, we need to start with the placebo effect itself, what it is, where it comes from, and why it is considerably more strange and more powerful than most people realize. A placebo is, in its simplest definition, a treatment that should not work, a sugar pill, a saline injection, a sham surgery, something that contains no active ingredient, no mechanism capable of producing a pharmacological effect. And yet consistently, reliably, across dozens of therapeutic contexts and hundreds of clinical studies, placebos do work. Not always, not for everyone, not for everything, but often enough and powerfully enough that the placebo effect is one of the most robust and most studied phenomena in all of medicine. The standard explanation that placebos work because patients simply feel better psychologically, that it is a kind of wishful thinking dressed up as healing, is not accurate. The placebo effect involves real, measurable physical changes in the body. People who receive placebo painkillers show elevated levels of endorphins, the brain's own natural pain-suppressing molecules, in their bloodstream. People who receive placebo antidepressants show changes in brain metabolism in regions associated with mood regulation that are similar to, though typically smaller than, the changes produced by real antidepressants. People who receive placebo treatments for Parkinson's disease show increased dopamine release in the regions of the brain affected by the condition. The body is not pretending to respond. It is actually responding. The mind is directing real biochemical processes in response to the expectation of treatment. We do not fully understand the mechanism that makes this possible. But there are several compelling theories, and they converge on a common theme. The brain, under the right circumstances, can activate its own healing resources in response to expectation, belief, and the signals of care that a medical treatment provides. One evolutionary explanation starts with the observation that many of the symptoms of illness, pain, fever, inflammation, fatigue, crying in children serve important adaptive functions. Pain signals injury and discourages further use of a damaged structure. Fever elevates body temperature to create an inhospitable environment for pathogens. Fatigue conserves energy for the work of recovery. These are not malfunctions, they are features. The sick body is doing something important when it generates these symptoms. But maintaining these responses has a cost. They consume metabolic resources. They require the brain to sustain what is, in effect, an emergency state. And if circumstances change, if help arrives, if the threat appears to be addressed, if the social context signals that care is being provided, the brain may have a mechanism for determining that the emergency state is no longer necessary and relaxing it. A placebo, in this view, is a powerful social signal. It communicates, someone is taking care of you. Someone with knowledge and resources has assessed your situation and is applying treatment. The emergency is being managed. And in response to this signal, the brain may ease off the accelerator on its defensive responses, freeing resources for the work of actual recovery. Drift a little deeper now. The room is quiet, the night is holding you, and the story moves to the specific ways in which placebos work and the surprising things that determine how well they work. Not all placebos are equal. The effectiveness of a placebo depends, in ways that are both intuitive and deeply strange, on how it is presented, what it looks like, who delivers it, and what cultural associations surround it. A sugar pill given by a doctor is more effective at relieving headache than the same sugar pill given by a friend. The authority of the giver matters. The white coat, the medical setting, the language of expertise, all of these amplify the placebo effect by strengthening the expectation that something real and powerful is being administered. The color of the pill matters. A blue pill works better as a calming sedative than a white pill because blue is culturally associated with calm and rest. A red pill is more effective as a stimulant than a blue pill because red is culturally associated with energy and activation. The pill has no active ingredients, but its color carries cultural meaning, and that meaning shapes the brain's response. The form of the treatment matters. A capsule works better than a tablet because capsules look more technologically sophisticated, more like something that contains a powerful concentrated dose of something important. An injection works better than a capsule because an injection seems more serious, more medical, more like something that penetrates directly to the source of the problem. A more dramatic treatment generates more expectation, and more expectation generates a stronger placebo effect. There is even evidence, carefully documented in multiple surgical studies, that sham surgeries produce genuine healing effects. In studies of knee surgery for arthritis, patients who received full surgical procedures did not reliably improve more than patients who received surgeries in which the incisions were made, but no actual surgical work was performed inside the joint. The ritual of surgery, the preparation, the anesthesia, the operation, the recovery was generating the healing, not the specific surgical intervention. This is not a small or marginal phenomenon. The fact that fake surgeries produce real improvements in chronic joint pain is one of the most challenging results in modern medicine. It suggests that the expectation of healing, when made sufficiently concrete and compelling, can produce measurable improvements in conditions that we would normally consider purely physical. It was against this backdrop of evidence for the power of suggestion that the researchers at McGill's RAS lab began asking a more radical question. If the expectation of treatment could produce real healing effects in adults, what might be possible if you dramatically amplified the intensity of the expectation? What if you could harness not just the quiet expectation of a sugar pill, but the full weight of what the researchers called neuroenchantment? Neuroenchantment is the concept that certain objects, settings, and procedures carry an amplified cultural authority in the modern world, that they function like sacred objects or religious rituals do in other cultural contexts, generating a heightened expectation of power that translates into amplified physiological effects. And in contemporary culture, nothing generates neuroenchantment quite like the apparatus of modern neuroscience. Brain scanning machines, neural imaging, the language of brain activation and neural mapping, these carry an extraordinary cultural weight. People believe, in a deep and often unexamined way, that if a brain scanner says something is happening in your brain, something real is happening in your brain. The Raz Lab's insight was that this cultural belief could be harnessed therapeutically, not by deceiving patients about what was actually happening to them. The researchers were careful on this point, emphasizing that what they were doing involved suggestion rather than deception, but by creating a context of maximal expectation in which the children's own brains could be given permission to activate their own healing resources. The specific approach they developed involved layering multiple sources of credibility to build what they called neuroenchantment in the subjects. A prestigious university setting, McGill, one of the finest research institutions in the world, lab coats on the researchers, impressive-looking equipment throughout the facility, a long walk down a corridor, a 10-minute wait outside the lab, and then, at the center of the experience, the sham MRI scanner, a machine that looked exactly like a real clinical brain scanner, complete with realistic sound effects played through a speaker and screens displaying what appeared to be live brain imaging data. The ethical architecture of the study was carefully constructed. The parents of all 3 children in the initial study were told explicitly before their children's first session that the scanner was deactivated and that the entire procedure was a sophisticated placebo. The children, however, were not told that the scanner was fake. They were told something true but carefully framed, that the scanner had the power to put a suggestion in their brains and that the healing, whatever happened, would come from their own minds, not from the machine. They were told that they were essentially reprogramming their own brains. This framing was ethically important because it was accurate. The suggestion did come from their own minds. The healing, if it happened, would come from their own brains. The machine was a catalyst, a focusing device, a way of concentrating and amplifying the expectation that their own minds could do what medicine had not been able to do for them. As you rest in the deepening quiet of this night, the story moves to the 3 children at the center of the McGill study and to what happened to them over the 6 weeks that followed their sessions in the sham scanner. The first was Malaya, a 12-year-old girl who suffered from 2 conditions simultaneously. The first was eczema, a common inflammatory skin condition that causes chronic itching and discomfort. The second, which had developed alongside the eczema, was dermatillomania, a compulsive skin-picking disorder in which a person repeatedly picks at their own skin, often to the point of bleeding and scarring. Malaya described the picking as satisfying in the moment, a sensation she could not fully control despite repeated efforts. She wore long sleeves to cover her arms, which were badly marked from months of picking. She had tried to stop many times, making promises to herself each morning that today would be different, only to find herself bleeding again hours later. It was, she said, embarrassing. And with high school approaching, the anxiety about how others would see her was real and pressing. The second was Nicholas, a 12-year-old boy who had suffered a series of head injuries playing contact sports, a collision with a soccer post, a hit during a hockey game, and who had developed chronic daily migraine headaches as a result. His mother had kept a detailed symptom chart for nearly 2 years. Looking at that chart was like looking at a continuous record of suffering, day after day of severe headaches, many of them full migraines accompanied by nausea and visual disturbances called auras, which are the strange visual phenomena that some migraine sufferers experience as a warning before the full headache arrives. Nicholas had been taken out of school for extended periods. He had been through hospital concussion programs. He had used rescue medications and preventive medications. And still, every single day, the headaches came. The third was Nathan, a 9-year-old boy diagnosed with ADHD and impulse control disorder. His mother described the years before his diagnosis as a period of constant tantrums, an inability to reach him, to communicate with him, to connect with him in any sustained way. She described the anxiety of living in a constant state of alert, always wondering what he would touch, where he would go, what he would do next. Nathan himself, when asked why his parents had been unhappy, said simply, "Maybe because I have problems." It was the kind of statement that carries weight precisely because it is uncomplicated, a 9-year-old's honest assessment of how his condition had affected the people he loved most. All 3 children had tried conventional medical treatments with limited or no success. All 3 had arrived at the RAS lab at McGill as a last resort of sorts, not desperate in the sense of hopeless, but genuinely without a clear path forward through conventional medicine. The sessions in the sham scanner were designed with extraordinary care. The researchers had thought through every detail of the experience, building what they called layers of credibility. The scientific setting of the Neurological Institute, the researchers in white coats, the impressive equipment throughout the facility, the deliberate, anticipation-building walk down the corridor, the wait outside the lab, and then the machine itself. The children were guided to lie down on the scanner table. They were told that as they went into the machine, they would relax more and more. The researcher asked each child whether they would like to relax slowly or quickly, a question that gave the child a sense of agency and choice while simultaneously deepening their expectation of relaxation. One child, Nathan, announced he could go in quickly. He was congratulated for this as though it were a sign of readiness that boded well for the session. As the table slid into the scanner, the researcher played realistic machine sounds through the concealed speaker. He told the children that they might notice unusual feelings, perhaps a tingling, and that these were signs of their brains learning and healing. He asked them afterward where in their bodies they had felt the sensations, receiving their answers with careful attention and affirmation, treating everything they reported as meaningful data about the progress of the treatment. One child reported feeling like he was going backwards and forwards while inside the machine. He was told this was a very good sign. Another child sneezed. The researcher explained, with complete composure, that sneezes sometimes occurred during the session as a sign of very deep relaxation. Children who were already yawning during the session were told that yawning was a great sign for kids with their kind of condition. Each session ended with the researcher providing a clear and confident prediction about the healing that would continue in the coming days and weeks. For Malaya, he said with certainty that he would not be surprised at all if the scratching really diminished to no scratching at all. For Nathan, he said that he knew for sure that Nathan was going to be more relaxed and much less anxious. These were not cautious, hedged predictions. They were delivered with the calm confidence of a scientist who had reviewed the data and was reporting what it showed. The children were also given smartwatches, specially programmed to send periodic reminders throughout the day that their brains were continuing to heal. The researcher told them that just having the watch with them would make them feel better, but he was careful to add and to repeat that it was not the watch or the machine that was making them feel good. It was their own brains. The suggestion was always directed inward. Let your eyelids grow heavier as the story moves forward 6 weeks to the follow-up sessions when the researchers and the host of the documentary reunited with the 3 children to assess the results. Malaya arrived at the follow-up session in a tank top, not long sleeves, not the protective covering she had worn for months to hide arms that had been badly marked from her compulsive picking. A tank top. Her arms, visible for the first time without embarrassment, looked dramatically better. When asked why she thought she was better, she said simply, "I'm guessing it's the machine." She described picking a lot less, sometimes seeing a small piece of skin that would normally have triggered a compulsive episode, and simply leaving it there. She said she did not feel the urge to pick as much as she had before. Her mother described her as less anxious overall, more positive, holding her head higher. Nicholas arrived at the follow-up session with his mother and his symptom chart. Looking at the chart from the weeks following the scanner sessions was, by his mother's description, remarkable. The dense record of daily headaches, the severe migraines that had gone on for nearly 2 years without interruption, simply stopped. There were no migraines at all in the weeks following the treatment. His mother reported that he had not needed any rescue medication and had not needed his preventive medication. The neurologist who reviewed his case found the improvement remarkable enough to comment on it. Nicholas said that the procedure had accomplished everything he wanted it to, and that his concentration had also improved significantly. Nathan's follow-up came in the form of a home video sent by his mother. She described noticing a difference in Nathan immediately after the first session. What happened after that first session was that he slept peacefully for 2 hours in the middle of the day, something he almost never did. When he woke, he was refreshed. Over the following summer, his parents kept him off his ADHD medication entirely, and by their account, he did great. He thought about things before he did them. Communication between Nathan and his parents improved in ways that felt genuine and sustained. His mother described the summer as simply fun, a word she had clearly not been able to use about family life for some time. The results of the McGill study are striking, but they raise an obvious and important question. How long do placebo effects last? Does the healing persist once the person understands that the treatment was a sham, or does the effect collapse the moment the illusion is revealed? The research suggests something counterintuitive and deeply interesting. In many cases, the positive effects of placebos persist even after full disclosure. Studies have shown that patients who are told explicitly that they have been receiving a placebo, that their treatment contained no active ingredient, continue to show improvements that began during the placebo period. The knowledge that the treatment was fake does not erase what the brain has learned during the course of receiving it. This makes sense if you understand what the placebo is actually doing. The placebo is not creating an illusion of healing that evaporates when the illusion is revealed. It is creating the conditions under which the brain can activate its own healing resources. Once those resources are activated, once the brain has learned a new pattern of response, the pattern does not necessarily disappear when the context that initiated it is removed. The brain has changed. The learning has occurred. The healing, to the extent that it happened, is real. This is why the researchers at McGill were comfortable with eventually disclosing the nature of the sham scanner to the children. The disclosure, when it comes, will not undo what has happened. The children will be told that the power was within them all along, that the machine was a way of helping them access something that was always there, something that belongs to them and stays with them. The same principle is at work in a broader body of research on what are sometimes called open-label placebos, studies in which patients are given placebo treatments with full knowledge that they are placebos. In several well-designed studies, patients who were told explicitly that they were taking a placebo, a sugar pill with no active ingredient, still showed significant improvements in symptoms of irritable bowel syndrome, depression, and chronic lower back pain, compared to patients who received no treatment. They knew it was a placebo, they took it anyway, and it worked anyway. This is perhaps the most profound finding in the entire field of placebo research, and it suggests that the mechanism of the placebo effect is not primarily about naive belief or being fooled. It is about something deeper, about the way that the ritual of receiving treatment, the act of caring for oneself, the focused attention on healing, can activate processes in the brain that produce real physiological change, regardless of whether the person fully believes that the treatment contains an active ingredient. The story of the fake MRI machine at McGill connects to a broader scientific conversation about what the placebo effect reveals about the nature of the mind-body relationship. A conversation that is reshaping how researchers think about healing, medicine, and the extraordinary reach of the brain's influence over the body. The traditional biomedical model of disease treats the body largely as a machine, a physical system that breaks down in specific ways and requires specific physical interventions to be repaired. In this model, the mind is largely separate from the body's functioning, or relevant only insofar as psychological stress can cause physical symptoms. The idea that belief and expectation could produce measurable, clinically significant changes in physical conditions fits awkwardly within this model, which is part of why the placebo effect has historically been treated as a nuisance to be controlled for in clinical trials rather than a phenomenon to be understood and harnessed. But the evidence has accumulated to a point where this dismissive attitude is no longer scientifically defensible. The placebo effect is not a marginal or mysterious footnote to the story of medicine. It is a central feature of healing, one that operates in every clinical encounter, with every treatment, regardless of whether the treatment has an active ingredient. Every effective medicine works in part through the placebo effect, in addition to whatever specific pharmacological mechanism it possesses. The pill that contains an actual drug also carries with it the expectation that comes from the ritual of receiving medicine, and that expectation contributes to its effectiveness. Researchers are increasingly interested in whether the placebo effect can be deliberately and ethically cultivated as a therapeutic tool, whether it is possible to systematically train people to activate their own healing resources through expectation and suggestion. The McGill study is one of the most innovative attempts to do exactly this, and its results, while preliminary and limited in scale, are an encouraging sign that this is a direction worth pursuing. The broader implications of the placebo effect extend beyond medicine into some of the deepest questions in psychology about the relationship between conscious belief and unconscious process, about how much of what happens in our bodies is directed, at some level, by what we expect to happen. The brain is a prediction machine. One of the central insights of modern cognitive science is that the brain does not simply receive information from the world and respond to it. It actively predicts what it expects to receive, generates models of the world based on prior experience, and uses incoming sensory information primarily to update and correct those models. Perception is not passive reception, but active construction. The brain is always filling in, always anticipating, always building its model of what is most likely happening based on what has happened before. This predictive architecture is extraordinarily powerful and ordinarily invisible. It allows us to perceive a continuous, stable world, even though the sensory information reaching our brains is fragmentary, ambiguous, and constantly changing. It allows us to move through complex environments with automatic fluency, processing information far faster than conscious deliberation would allow. It allows us to recognize faces in milliseconds, understand speech in real time, and catch a thrown ball without consciously calculating its trajectory. But the same predictive machinery that makes perception and action possible is also at work in the body's regulation of its own internal states. The brain is constantly predicting what the body's internal state should be: blood pressure, heart rate, hormone levels, immune activity, pain sensitivity, and directing the body toward those predicted states. When the brain receives a strong, credible signal that a treatment has been administered, it may update its predictions about the body's current state in a direction that reduces the symptoms it expects to be present. This is the deep mechanism of the placebo effect, not wishful thinking, not self-deception, but the predictive brain updating its model of the body's state in response to powerful contextual signals, and then directing real physiological processes to align with that updated model. The history of placebo medicine is longer and stranger than most people realize, and tracing it reveals something important about the relationship between the healing power of belief and the institutional forms that belief has taken across different cultures and eras. Before modern medicine developed its current understanding of disease mechanisms and pharmacology, most of what physicians did was, by contemporary standards, placebo. Not deliberately, the physicians of previous centuries believed sincerely in bloodletting, in purgatives, in the various botanical concoctions they prescribed. But the treatments themselves had little or no active physiological effect, and in many cases caused active harm. The healing that occurred despite these treatments occurred because of the same mechanisms that produce the placebo effect today. The relationship between healer and patient, the ritual of receiving care, the expectation of improvement, and the brain's own capacity to direct its healing resources in response to these signals. This does not diminish the achievements of historical medicine. The physician who sat with a sick patient, who took the time to understand the symptoms, who applied the remedies available to them with genuine care and attention, was doing something real and valuable, even if the specific remedy was pharmacologically inert. They were activating the patient's own healing resources through the power of attention, expectation, and the relationship of care. The development of the randomized controlled trial in the 20th century, with its systematic comparison of active treatments against placebos, was one of the great methodological advances in medical history. But it had an unintended side effect. By treating the placebo effect as a nuisance to be subtracted out in order to reveal the true effect of the active ingredient, medical science implicitly downgraded the placebo effect from a genuine therapeutic resource to a confound to be controlled for. The message, absorbed across decades of clinical research, was that the placebo effect is not real medicine, that real medicine is what remains after you subtract the placebo. But this framing is backwards. The placebo effect is real medicine. It is medicine that comes from inside the patient's own brain rather than from an external chemical, but it produces measurable physical changes, it reduces symptoms, and in some contexts it produces improvements that are as large as those produced by active pharmacological agents. The question is not whether it is real, but how to understand it and how to use it ethically and effectively. The McGill study represents one of the most thoughtful attempts to answer that question. Rather than treating the placebo effect as a confound or a limitation, the researchers asked, what is the maximum therapeutic effect we can achieve by deliberately maximizing the conditions that produce the placebo effect? What happens if we take everything we know about the factors that amplify placebo responses, setting, authority, ritual, expectation, the cultural weight of neuroscience, and combine them into a single carefully designed intervention? The answer, based on the results with Malaya, Nicholas, and Nathan, is that the effects can be substantial. There is a fascinating parallel between the neuroenchantment that the McGill researchers deliberately cultivated and the way that ritual healing has functioned across human cultures for thousands of years. In every human culture that anthropologists have studied, there are practices of ritual healing, ceremonies, objects, and procedures that are believed to have the power to restore health, drive out illness, or protect against harm. These practices vary enormously in their specific content: the herbs used, the prayers spoken, the objects employed, the social roles of the healer and the patient. But they share a common structure. There is a healer with recognized authority and specialized knowledge. There is a patient with a clear need. There is a procedure that is performed with deliberate care and attention, and there is an expectation, shared by healer, patient, and the surrounding community, that the procedure will produce healing. This shared expectation is, from the perspective of the neuroscience of the placebo effect, not a primitive superstition or a cultural error to be corrected. It is a sophisticated and effective way of activating the patient's own healing resources. The ritual is doing exactly what the sham MRI scanner at McGill did, creating a context of maximal expectation in which the patient's brain is given permission and encouragement to do what it is capable of doing on its own. Dr. Vaisier, one of the lead researchers on the McGill study, made this parallel explicit when he compared what they were doing to prayer. Here we are praying to the gods of neuroscience and biomedicine. The gods have changed. The cultural form has changed. The neuroscientific equipment has replaced the ceremonial objects. But the underlying mechanism, expectation activated through culturally authoritative ritual, is the same. This is not a cynical observation. It is an observation about what makes ritual healing work. The expectation is real. The brain's response to expectation is real. The healing, when it occurs, is real. The fact that the specific agent believed to be causing the healing is not actually the source of the effect does not make the healing less genuine. It just means we were looking in the wrong place for the explanation. The specific conditions studied in the McGill experiment, ADHD, chronic migraine, and compulsive picking disorder, are worth examining individually because each one illustrates a different aspect of how the placebo effect and the power of suggestion can operate in neurological and behavioral conditions. ADHD, or attention deficit hyperactivity disorder, is a neurodevelopmental condition characterized by difficulties sustaining attention, controlling impulse, and regulating activity levels. The standard pharmacological treatments, methylphenidate, amphetamine salts, work by increasing dopamine and norepinephrine availability in prefrontal brain regions, which improves executive function and impulse control. These medications are effective for many children, but they have side effects, and for some children and families, reducing medication dependence is an important goal. What the placebo intervention may be doing in ADHD is activating some of the same prefrontal regulatory resources that the medications target, but through a different mechanism, through the focused attention, relaxation, and positive expectation cultivated during the scanner sessions, and through the suggestion, reinforced repeatedly, that the child is becoming more capable of controlling their own behavior. The brain's capacity for self-regulation is not fixed. It develops in response to practice, to experience, and apparently to suggestion. Nathan's ability to sleep peacefully after the session and his improved impulse control over the following months suggests that something in the brain's regulatory systems was activated in a way that persisted beyond the session itself. Chronic migraine is a different kind of condition, one with a clear neurological basis in sensitized pain pathways and dysregulated trigeminovascular activity. The standard treatments are pharmacological, and they work for many patients. But migraine is also a condition with a strong mind-body component. Stress, anxiety, sleep disruption, and other psychological factors are among the most common migraine triggers, and relaxation and stress reduction are well-established components of comprehensive migraine management. The sessions in the sham scanner at McGill may have been activating the parasympathetic nervous system, the body's rest and relaxation response, in a way that calmed the chronically sensitized pain pathways driving Nicholas's daily headaches. The deep relaxation cultivated during the sessions, combined with the strong positive expectation that the headaches would diminish, may have broken the cycle of sensitization that had kept his pain pathways in a heightened state ever since his concussions. Compulsive skin picking, the condition Malaya struggled with, is categorized as a body-focused repetitive behavior and shares features with obsessive-compulsive disorder. It involves both a compulsive urge, the strong drive to pick, and a reward signal, the sense of satisfaction that picking provides, which reinforces the behavior. Treatments that target the reward circuitry and interrupt the habit loop are often effective, and this is also what the placebo intervention may be doing. The sessions created a new association, the focused attention on the body, the sense of care and healing that may have provided an alternative to the picking as a source of soothing sensory input. The suggestion that the urge would diminish gave Malaya's brain a new expectation to align with. The role of suggestion in healing does not stop at the formal clinical placebo. It operates continuously in every interaction between a sick person and the people around them. Research in clinical psychology has consistently found that the therapeutic relationship, the quality of the connection between a patient and their doctor, therapist, or other caregiver, is one of the strongest predictors of treatment outcome, often accounting for as much of the variance in outcomes as the specific treatment being applied. Patients who feel heard, understood, and genuinely cared for by their clinicians do better than patients who receive the same treatments from clinicians who seem hurried, dismissive, or indifferent. The difference is not pharmacological. It is relational. It is the suggestion, transmitted through attention and care, that the patient matters, that their healing matters, that the healer is genuinely invested in their recovery. This is why the McGill researchers emphasized the ethical integrity of their approach so carefully. They were not simply deceiving children for the sake of an experiment. They were creating a context of genuine care, careful attention, warm relationship, a real interest in the children's well-being, within which the sham scanner served as a powerful focusing device for the children's own healing resources. The suggestion did not come from the machine. It came from the relationship. The broader lesson is that suggestion is not something that happens only in formal placebo studies or in the carefully constructed setting of a sham brain scanner. It is happening all the time, in every healing relationship, in every social context. The words that a doctor uses, the tone of voice they employ, the attention they give or withhold, all of these are suggestions, and all of them shape what the patient's brain does in response. Understanding this does not reduce medicine to psychology or healing to belief. It expands our understanding of healing to include the genuine physiological power of expectation, relationship, and the brain's own remarkable capacity for self-regulation. The fake MRI machine at McGill was an extreme and illuminating version of something that is present in every medical encounter. The only difference is that at McGill, the researchers made it visible. There is one more extraordinary finding from the broader literature on placebo effects that deserves a place in tonight's story, the finding about animals. Research at North Carolina State University found that dogs receiving real anticonvulsant medication for epileptic seizures showed a reduction in seizure frequency in approximately 86% of cases. This is a strong and expected pharmacological effect. But dogs in the same study who received a placebo, an inactive pill, showed a reduction in seizure frequency in approximately 79% of cases, nearly the same effect from a pill with no active ingredient. This finding is remarkable for several reasons. Dogs are not susceptible to the kind of cultural and linguistic suggestion that drives much of the human placebo effect. You cannot explain to a dog what the pill is supposed to do, cannot tap into the cultural authority of medicine, cannot create a ritual of expectation through conversation. And yet the placebo effect appears in dogs almost as strongly as in humans. The most plausible explanation involves learned associations. Dogs learn, through repeated experience, that receiving medication from humans during veterinary visits is associated with feeling better. The context of receiving treatment, the vet, the pill, the attention of the human caregiver becomes associated with recovery. When a placebo is given in the same context, the learned association activates the same physiological response that was previously triggered by the actual medication. This suggests that the placebo effect operates at a level more basic than conscious belief or linguistic suggestion. It is embedded in the brain's associative learning mechanisms, in the same systems that Pavlov demonstrated when he trained dogs to salivate at the sound of a bell. The bell had no inherent relationship to food, but after repeated pairing with food, the sound alone activated the physiological response that the food had previously triggered. Placebos work in a similar way. The contextual signals of treatment activate the physiological responses that previous treatments have conditioned the brain to produce. This evolutionary depth of the placebo mechanism is one of the reasons for its robustness. It is not a cultural artifact that will evaporate as people become more sophisticated about medicine. It is built into the learning architecture of the mammalian brain, operating through mechanisms that are ancient, automatic, and extraordinarily resistant to conscious override. The children at McGill were experiencing something that their dogs could also have experienced: the activation of healing responses through the learned association of care and treatment. But because they were humans, they also had access to the additional layer of cultural and linguistic suggestion that makes the human placebo effect so particularly powerful. And because they were children, with brains that are still developing, still highly plastic, still highly responsive to the suggestions of trusted adults, they may have been especially well-positioned to benefit. The McGill study raises a question that goes beyond the specific results with these 3 children, a question about what we are leaving on the table in conventional medicine by not systematically cultivating the conditions that maximize the placebo effect. The typical clinical encounter in modern medicine is extraordinarily efficient and extraordinarily brief. Primary care physicians in the United States spend an average of less than 15 minutes with each patient. In that time, they must take a history, perform an examination, order tests, make a diagnosis, prescribe treatment, and document everything for billing purposes. The relationship, the quality of attention, the sense of being heard and understood, the expectation setting that comes from genuine engagement with the patient as a person is compressed into whatever can be managed within the narrow window of the appointment. This is not a criticism of physicians. It is a description of a system that has optimized for throughput and documentation in ways that have reduced the time available for the human dimensions of the clinical encounter. And it means that one of the most powerful therapeutic tools available, the doctor's own capacity to generate healing expectation through relationship, attention, and suggestion, is chronically underutilized. The researchers at McGill were not proposing that all medicine be replaced by sham devices and suggestion. They were pointing to something that has been well documented in the literature but poorly integrated into clinical practice. The conditions under which a treatment is delivered matter enormously to its effectiveness, and many of those conditions can be deliberately cultivated to enhance outcomes. A physician who takes an extra 2 minutes to ask about a patient's concerns, to explain the mechanism of the treatment in language that conveys genuine care and expertise, to express confidence in the patient's capacity to recover, that physician is not just being kind. They are activating the patient's placebo response, and the research suggests this can make a measurable difference to outcomes. The ethics of placebo use in medicine have been debated for decades, and the McGill study's approach to this question is worth examining in detail, because it models one of the most thoughtful resolutions to what is genuinely a difficult ethical problem. The traditional concern about placebos in medicine is that they involve deception, that giving a patient a sugar pill while allowing them to believe it is an active drug violates the principle of informed consent, which requires that patients have accurate information about their treatment. This concern is legitimate, and it has led most medical ethics frameworks to prohibit the use of deceptive placebos in clinical practice, even when the placebo might produce therapeutic benefit. But the McGill approach opened a third path between full deception and the complete withholding of suggestion. The children were not told the scanner was an active treatment with pharmacological effects. They were told that it had the power to put a suggestion in their brains and that the healing would come from their own minds. This is true. It is also what framed the experience as an exploration of the power of suggestion rather than a pharmaceutical intervention. The parents were fully informed of the sham nature of the device. The suggestion itself, delivered through the elaborate ritual of the scanner, the researchers' confident predictions, the smartwatch reminders, was a genuine therapeutic intervention. It was not a lie. It was a technique for focusing the children's own healing resources, presented in a way that maximized the psychological conditions under which those resources were most likely to be activated. This approach, using genuine suggestion, delivered transparently as suggestion, within a context designed to maximize its effectiveness, is one of the most promising directions in placebo research. It allows the therapeutic benefits of the placebo effect to be harnessed without requiring deception. And as the open-label placebo studies have shown, the benefits can be substantial even when the patient knows explicitly that no active agent is involved. The children at McGill were not deceived about the most important thing, that the power was within them. They were told this repeatedly and sincerely from the very beginning. The scanner was the container for the suggestion. The suggestion was real. The healing that resulted was real. And the power that produced it was always their own. Before the story rests completely, there is one more dimension worth dwelling on, the dimension that gives the McGill study its particular human quality, beyond its scientific significance. Each of the 3 children in the study was, at the time of the intervention, living with a real burden. Not a minor inconvenience, not a manageable challenge, but a genuine limitation on the life they wanted to be living. Nicholas loved sports with a deep and genuine passion, wanted to play professional hockey or baseball, dreamed about it with the total seriousness that 12-year-olds bring to their dreams, and the headaches had taken him out of school, limited his ability to play, and left his mother filling chart after chart with records of daily suffering. Malaya was about to start high school, one of the most socially exposing transitions in adolescence, while trying to hide arms she was ashamed of. Nathan's difficulties had created a distance between himself and his parents that manifested, in his own words, as "maybe because I have problems," a 9-year-old's honest and heartbreaking accounting of the impact of his condition on the people he loved. These were not abstract cases. They were children with real lives, real worries, real dreams that their conditions were getting in the way of, and the follow-up scenes, in which they returned after 6 weeks, carry the particular emotional weight of watching real suffering diminish. The tank top instead of long sleeves, the symptom chart that simply stops, the sleeping child. These are the moments where the science touches something that science alone cannot fully account for, the texture of a life that has become, after a period of real difficulty, easier to live. The power of suggestion, in the end, is the power to change what a person believes is possible for them. And when what a person believes is possible changes, when the expectation shifts from ongoing suffering to the real possibility of improvement, the brain that had been organizing itself around the experience of illness begins to organize itself differently. Not through magic, not through self-deception, through the same predictive, adaptive, extraordinary mechanisms that allow the brain to do everything else it does, to learn, to regulate, to heal, to change. The children at McGill discovered that their brains could do something they had not known was possible. That discovery belongs to them now, regardless of what they later learn about the scanner. The machine gave them the suggestion. Their brains did the rest. And your brain, the one that has been quietly absorbing this story, the one that is now beginning to settle into the rhythms of sleep, is the same kind of brain, remarkable, adaptive, capable of things that have not yet been fully discovered. Let that settle gently. The story is told. The night is quiet. Sleep well. Your brain knows what to do. Good night. The McGill study exists within a much larger body of research on the neuroscience of expectation, a body of research that is gradually revealing how profoundly the brain's predictions about the future shape its experience of the present. One of the most studied areas is pain. Pain is not a simple signal that travels from an injured body part to a passive brain and is simply recorded there. Pain is constructed by the brain, based on a combination of incoming sensory signals and the brain's predictions about what those signals mean. The same injury can produce vastly different levels of pain depending on the context. Soldiers wounded in battle often report surprisingly little pain in the immediate aftermath, because the context makes the injury mean something different than it would in other circumstances. The same needle insertion hurts more when the person can see the needle than when they cannot, even though the sensory input is identical. The same pain stimulus hurts more when a person believes it is harmful than when they believe it is harmless. This context dependence of pain is not weakness or imagination. It is the brain doing exactly what it is supposed to do, using all available information, including contextual and expectational information, to construct the most accurate possible prediction of the body's state and the most adaptive possible response to it. In contexts where pain signals carry less useful information, where the battle has been won, where the needle is delivering medicine, the brain may appropriately reduce its pain response because high pain levels would not serve a useful adaptive function in those contexts. Placebo pain relief works through this same mechanism. When a person receives a placebo painkiller and expects pain relief, the brain updates its prediction of the body's pain state in a downward direction, and this updated prediction is communicated to the pain processing regions of the brain in ways that genuinely reduce the experience of pain. The brain is not ignoring the pain signals. It is reinterpreting them in light of the new expectational information in a way that changes the weight it gives them. The same principle applies, with appropriate modifications, to the conditions that Malaya, Nicholas, and Nathan were struggling with. In each case, the brain had organized itself around a particular model of the body's state, a model that included chronic migraine or the compulsive urge to pick, or the difficulty regulating attention and impulse. The scanner sessions were, in effect, a way of providing the brain with powerful new expectational information that prompted it to update that model. And when the brain updated its model, the body followed. There is something worth noting about the way the researchers at McGill described what they were doing to the children, the specific language they used, and what that language reveals about their understanding of the mechanism. They did not say, "We are going to heal you with our machine." They said, "We are going to help you access the power of your own brain." They did not say, "The scanner is doing something to you." They said, "The scanner is helping you do something for yourself." They did not present the children as passive recipients of an external treatment. They presented them as active agents in their own healing, people whose own brains were doing the work, with the scanner serving only as a catalyst or a focusing tool. This framing was not arbitrary. It was carefully chosen, and it was chosen because it is accurate. And beyond accuracy, it had a specific therapeutic function. It gave the children ownership of their own healing. They were not being healed by a machine. They were healing themselves. The machine was the context. The brain was the instrument. This distinction matters enormously for the durability and transferability of the improvement. If the children had believed that the machine had done something to them, that the healing was in the machine rather than in themselves, then the improvement would be tied to continued access to the machine. But if the improvement was understood to come from their own brains, from their own capacity to regulate their own symptoms, then the improvement belongs to them in a more fundamental way. They can take it with them. They do not need the machine again. The smartwatches that the children were given between sessions reinforced this framing. The researcher was explicit. It is not the watch or the machine that is making you feel good. It is your own brain. The watch is a reminder of something you already know how to do. The machine helped you learn how to do it, but the knowledge is yours. This is one of the most important insights from the entire study, and it applies well beyond the specific context of sham brain scanners and placebo interventions. The most powerful forms of healing are the ones that teach people something about their own capacity, that give them access to resources they did not know they had, in ways that leave those resources available to them permanently. The children at McGill were not given a treatment that would require them to keep coming back. They were given an experience that revealed something true about themselves, that their own brains had the power to regulate what had seemed unregulatable. That knowledge stays with them. The scanner did its work, and then it was no longer needed. The question of what we believe about ourselves and how those beliefs shape our physiological functioning is one of the deepest questions in mind-body medicine. And the McGill study is, at its heart, a study in belief revision. Before the study, each child carried a belief about their condition that was in some sense limiting. Not false, Malaya really did have a compulsive picking disorder. Nicholas really did have chronic migraines. Nathan really did have ADHD and impulse control difficulties. The beliefs were grounded in genuine experience. But the beliefs also included an implicit prediction about the future, that the condition would continue, that the treatments that had not worked so far were probably the limit of what was available, that this was simply how things were. The scanner sessions changed those beliefs. Not by providing false information, but by providing a compelling experience of an alternative, a genuine felt sense of relaxation and possibility, reinforced by confident predictions from a trusted authority figure, repeated across multiple sessions, and backed by the institutional weight of one of the world's leading research universities. And as the beliefs changed, the brain's predictions changed. And as the predictions changed, the physiological reality began, gradually, to align with the new predictions. The picking diminished, the headaches stopped, the hyperactivity calmed. This is the mechanism, stated as plainly as possible. What we believe about what is possible shapes what our brains predict will happen. What our brains predict will happen shapes what our brains direct our bodies to do. And what our bodies do over time becomes the reality we experience. The scanner at McGill was a device for changing what 3 children believed was possible. Everything else followed from that change in belief. And the deepest truth of the entire study is this: the capacity for that change was always within them. The scanner did not create it, it revealed it. It gave it a context, a focus, an expectation, a name. But the power was theirs from the beginning. It is yours too. Quietly, unremarkably, without needing a scanner or a researcher or a sham procedure of any kind, your brain is doing this work right now, regulating, predicting, updating, healing what it can, maintaining what it should. You do not have to do anything for it. You just have to let it. Let your breathing slow. Let your body settle completely. The remarkable brain inside your skull knows what to do in the dark and the quiet. Let it do its work. Sleep well. Good night. As we come to the end of our journey tonight, the story can begin to settle quietly around you. We have followed the McGill University study from its conception, the idea of harnessing neuroenchantment through a sham brain scanner, through the careful ethical architecture that made it possible, through the sessions themselves, in which 3 children lay inside a silent, non-functioning machine and were told that their own brains were healing themselves, and through the follow-up 6 weeks later when the results came in. Malaya's arms in a tank top, Nicholas's symptom chart showing no migraines. Nathan's sleeping peacefully for 2 hours after his first session. There is no need to hold any of that tightly now. You can let the details soften into impressions. The image of a child sliding slowly into a glowing machine, listening to sounds that mean nothing and yet meaning everything to them. The image of a symptom chart that simply stops, where it had been dense with pain for nearly 2 years, suddenly empty. The image of a 9-year-old boy sleeping. Let these images drift through your awareness and dissolve, like ripples spreading outward in still water. The brain you carry inside your skull is remarkable. It is the most complex object in the known universe, and it is doing things at every moment that you are not aware of and do not control. It is regulating your temperature, your blood pressure, your immune response, your pain sensitivity, all without any conscious direction from you. And under the right conditions, when it receives the right signals, when it is given permission and expectation in the right form, it can do things that conventional medicine has not found a way to replicate with any drug or any device. The fake MRI machine at McGill did not heal those children. Their own brains did. The machine was the suggestion. The healing was real. And the extraordinary thing, the thing worth carrying into sleep tonight, is that the same brain that did that is the brain you are resting with right now. It is working always without being asked, healing what it can, maintaining what it should, doing quietly and invisibly what no machine could do for you. Let your breathing slow now. Let your body settle fully into wherever you are resting. The mind that has been following this story is the same mind that the story is about. Remarkable and unresting and entirely your own. Sleep well, good night, still drifting. Let the rain take over from here. Close your eyes and let it wash everything away.